start after the peak, at the peak or after. So this is the peak of the contraction, the highest point. The late would have to start there or right after. And then it has to last 30 seconds and then return to baseline.
Return to baseline after the contraction's over?
Yes. Everybody good with lates? Okay. And it's just usually saying the placenta is not giving us enough blood. So that's commonly seen in like post-dates patients that are past their due date. So they're like 41 weeks. You know, their placenta's old. The placenta is like only built for 40 weeks, and as it ages, it starts calcifying and getting fragile and not like oxygenating like it should be. Causes that, or like people that have hypertension, if they have high blood pressure all the time, that those vessels are a lot more fragile. That can cause that. If they have diabetes, then they're having high sugar in their placenta all the time. It can cause calcification, all those things. So there's lots of reasons they can have late.
Doesn't it get hard?
Yeah, it will calcify.
The longer it calcifies. I got to feel it today, and I like touched.
Yeah, so it'll get, it's soft, it's like meat, and it gets like little, like granule type
it was
things
cool.
in it. It's white. You can see it, and that is where it's not, the blood's not flowing through there. So if our patient has D cells that are worrisome, we do uterine resuscitation measures. So that would be repositioning the patient. So if it's a cord, we're going to turn them because maybe the baby was laying on it when they're like this, but if we turn them over this way, now the baby's not laying on the cord anymore. It might not
Is that an
compress.
opportunity to put them on the right side?
Yeah. So
the only time you get to put them on the
yeah,
right side.
yeah, they're usually on their left side, but we do put them on the right side. We actually change position every 2 hours at least, but left is the adequate position. But we keep, you know, rotating, especially if they're having D cells, to try to get that to go away. Second thing is giving them IV fluid bolus. So that is giving them a lot of fluids quickly. Usually if you're doing on a pump, it's running it at 999. That's as fast as the pump will go.
Wow.
Or we take it off the pump and just
let it
open
gravity.
it, and gravity just runs it in as fast as it'll go. We can do, you know, a liter, 500 cc's, whatever you need, depending on how bad the decelerations are. But what that's doing is that's increasing mom's perfusion, so then that increases baby's perfusion, hopefully, right? So that sometimes will help if maybe her blood pressure dropped after the epidural. So now mom and baby aren't getting enough blood, so we increase their volume, and now they're getting enough.
Makes sense.
You wouldn't do that if they were hypertensive causing that, though, would you?
Well, we might. So we try not to give them too much because we can fluid overload our patients. We do sometimes because during their labor and delivery stay, we give them 4 liters of fluid, average. But sometimes they'll get more. So if they were here for a long time and their babies was having D cells for a long time, they might get bolused by multiple different nurses and then end up with a lot of fluid, and then they do get fluid overloaded. But we'll try not to. But sometimes patients that are hypertensive, they might have a blood pressure of like 130/70, and their baby might have D cells because they're used to having a blood pressure of 150/70, and so that's low to them, but not low to us.
Got it. It's
so they might need a little bit of a higher pressure to
situation.
keep the baby